Typically, a Kaizen event is a short duration, a short period of time where you do rapid improvements. It's analogous to if you were going to eat the elephant, maybe take the whole leg in 4 days, and then you're left with action items at the end of the event. So it's very episode, or we say episodic type of improvement events. Kata is a routine for practicing and becoming a part of your daily continuous improvement culture. It's taking small steps, so maybe just a small bite of the elephant. The 5 questions keep you focused and targeted on how do you want this process to operate in the next week or 2 weeks out, and what obstacles are keeping you from operating in that target condition. We sit back and look at the current situation and then develop experiments or PDCA cycles to try and go around those obstacles to get one step closer to that target condition. Every day a step closer, and all of this is in line with the vision and the challenge for the company.
Okay, welcome everyone to this part of our series with Baptist Memorial Healthcare DeSoto Hospital. We've got Katie Burr, Quality Director, and Kasie Fowler, Risk Management Director, and Amy Kirby, Infection Prevention Nurse Manager there at Baptist DeSoto. And we're going to be talking today and go a little bit deeper into the planning and maybe some of the frontline work and some of the incident command that we've already talked about in previous interview sessions. And these ladies are going to tell us a little bit about some of the things that they did. So let's just start off with Amy. You were on the incident command team, and just talk to us about those first few weeks. You know, we heard about all of the hot spots, and it got to New Orleans, and then I'm sure it was kind of getting a little closer there to Memphis, and you had your first few patients, or how you prepared for that. So help us understand from the incident command position, what was it like there, and what were your first few patients that came through the door? What was the planning process as it came down from that?
So even before we formed Incident Command, we had been hearing about this unknown virus that had crept up in Wuhan, China, and we get HAN alerts, or we get alerts from the Health Alert Network from the state of Mississippi, and we've been following this. And as a part of an infection preventionist job, it's not only to look for hospital-associated infections, but also community-associated infections such as influenza that may impact the hospital's capacity to care should you have an influx of patients. So we've been watching this, and we started meeting early on, even before any of the first patients ever even came to Memphis, or even the United States. So we started meeting, and we realized very quickly that one, there were too many people in the room. And not that we were trying to social distance back then, it's just that it's very difficult to hear and to communicate and understand in a manner that's more structured. So we ended up going from just a regular meeting to a more formal incident command structure, which is typically used whenever you're responding to a disaster event or a pandemic event, which this eventually became. With that kind of structure, you of course have your incident commanders, and then you have folks that are in charge of planning and operations and logistics and that kind of thing. So it just enables a better structure. Things get done a lot quicker. If I had this to do over again, and I hope I never do, but if I did, I would always use this incident command structure. That's really what it was designed to do. And I can't imagine doing it any other way. Early on, also, one of the things that I think really helped us in our subsequent stages and planning and operationalization of the plans, I think that getting all of the staff before it really hit our area, getting all of the hospital employees together for an emergent or a few emergent town hall meetings enabled us to reduce the amount of panic that we anticipated would occur when these folks started hearing about it. Healthcare is scary. Healthcare is really scary in the midst of a pandemic.
Right.
And we knew that we would have to be quickly planning and moving things around and adjusting. So the first thing we wanted to do was to calm the staff so that we wouldn't have to also be dealing with that while we were having to plan and implement. So I think that was key, was to provide education, squelch any myths, you know, and that kind of thing. And I think that really helped us, those two things, incident command and early on preventing any panic in the staff, I think were keys to our subsequent success.
That's great. That's great. And for our audience and those that have been following Baptist or read any of Skip's architecture, the Baptist management system, I think very many of us are aware of the Baptist management system. All three of you are trained in that as far as TWI job relations and job methods. Katie, you're a job methods trainer and an ambassador for the Baptist management system between hospitals. And Kasie, you and Amy have backgrounds in that and work in the A3 areas and stuff. So you mentioned Amy, it being a kind of a calming effect. And this is for any of the three of you. How did the Baptist management system or using those tools, I know you probably didn't do it in a formal improvement Kata storyboard and go through all the 5 questions. You probably didn't do a lot of formal things that when you were first learning the system. Help our audience understand the effects of the Baptist management system and maybe some of the things that scenarios or some of the things that went on that the Baptist management system may have helped with.
I can speak to that. I think that one of the things we realized early on is that our staff were going to be our most important assets and our most important resources, and we had to protect them. And again, like I said, we met early on with them, listening to them, actively listening, looking for any themes that might indicate that there's some sort of panic going on, or that, you know, people are wanting to leave, those kinds of things. And then also visiting with the staff, going directly to them after we had our town hall meetings, going directly to them to hear their concerns. Lots of those concerns were brought to incident command. So I think just recognizing that they were, you know, our most important asset through this, and visiting them really is one of those things that we took from the job relations tactics. So that's certainly another thing I would do again if I ever had to do this again.
Right. Respect for people and
Respect for
empathy,
people, yes.
empathy that they are dealing with a very high stress, high risk situation there
Yes.
with the front line.
And even our team leaders, even or rather our senior leaders, they made rounds throughout the day. They made rounds on the weekends. They just really got close with our staff, listened to our staff. It was like nothing I had ever seen before. You know, really and truly, it was amazing. And it really, it just made us feel even closer together and even more empathetic of one another. And I think that the front line really had I think it had a profound effect on them in terms of recognizing that their senior leadership team really did care about their safety, and that we had some real concerns, you know, to make sure that they were okay, and that we were doing as much as we could, you know, for them.
Sounds like the leadership team or executive team were led by example, and we're real close to those frontline workers, and as well as middle managers. Katie, as a quality director, what were maybe some examples that you noticed, or maybe there was some teams you were on that there were obstacles that came up that you had some experiences that you had to kind of do some experiments around, or you had to think from a Kata standpoint, okay, here's where we're at now, here's an obstacle from where we're trying to get to, and we got to remove that. Do you have any instances of that you can
Absolutely. So I wouldn't call it a Kata board. That's not what we officially called it.
Right.
But as we pulled out of incident command, planning everything went through planning. So how we bring patients into the hospital, how we transport them around the hospital, how we wear or don and doff our PPE, how we take patients for procedures, everything changed. So we put together an hour meeting every day with planning and operations. So that was where we played catch ball a lot. We went to the gemba a lot to look at what's our current condition, what's our current process. Like Amy said, got feedback from staff. Well, what if we did this? Because they were working on those units every day. So we wanted to make sure whatever processes or anything we put into place that, you know, was very mindful and doable by the people doing the work. So I call that like a mini Kata, because we played catch ball, and then we would come and we would reevaluate. There were a couple of plans that we got feedback on, hey, this isn't working, you know, and so we would assess, you know, what's not working, what's your barriers, what's your thoughts. And I mean, we had, you know, our documentation, clearly you can see in our policies where they were updated as needed, and with the feedback that we received from the staff. So we didn't call it Kata, but we met every day for an hour and sometimes 2 hours trying to develop and PDSA all the processes we put into place to make sure we're keeping everybody safe.
Yeah, that's great. At this last Kata conference that we had, it was the 6th one. Mike Rother mentioned, I think it was this last one. He mentioned a company that he had worked closely with as he was writing the book. Now, this was several years ago, 10 years ago or so, and he came back like 5 years later after they had started with the storyboard and the questions and everything, and which many of us refer to that as the starter Kata. That's what we start with, a rigid routine of the questions and the storyboard, and then we detach from that a little bit, and we start to separate. You know, that's meant to teach the process. Then the thinking and muscle memory starts to come in place. Long story short, he said, I was going to be disappointed if I went back 5 years later and saw them doing the same thing, staying with the 5 questions and not progressing. And he said they hadn't. They had the thinking down, and they were addressing the issues with current condition. What's our target condition? Where are we at now? What's the current condition? What are our obstacles? And all those conversations were going on around every issue that they were having, but they didn't necessarily have the formal storyboard, if that makes sense. And there's a few areas where they were teaching new people how to do that, because they needed to start with the training wheels on. They needed to start with the starter Kata. Mm-hmm. But the people that had been there and experienced that, they'd been able to ingrain that into muscle memory. So that's great to hear. Kasie, how about you? Any of your teams experience any challenges or anything that you remember that were just very creative ways that they addressed this virus as it came in the doors?
Well, you made the comment about, or Amy made the comment about our staff and rounding on our staff and forming that trust with them. But inside of our incident command, every day we learn to respect and trust each other more and more, to the point where when we came up with our plans and we took our plans to incident command, there were no questions about, is this the right thing to do? Is this how we need to do it? It was, okay, planning's checked off on it. Now operations is going to go make it happen. And that's something that the structure of our incident command helped with, but without that trust and respect, I don't think that we would have been as successful as we had been. And as Katie said, my background as a risk manager, I'm trained in PDSA. That's, so we're always evolving, always trying to get better. So even just yesterday, Katie and Amy and I decided, hey, let's go back and look at some of our plans. We haven't, we haven't looked over them in a while. Let's see if we need to update anything. Let's see if there's anything we need to change. Let's get on the CDC website and make sure that we're up to date on our evidence-based practices. And that really has been something that I've been proud of. Getting to work on the planning committee has been challenging, because everything kind of starts here. I think everybody's position on incident command is challenging, but
but it has been a great opportunity to really walk our processes. Like Katie said, my first thing, I'm like the gemba goddess. Every time we do, I say, let's just go look at it. Let's just walk it. And
Gemba
that has
goddess.
been really beneficial. So
I love that, the gemba goddess. I love that part.
I'm the silly one in the bunch, by the way.
Yeah. So that made me think about something. So came from incident command, you got the plan together, and this is what we want to do. Then you go and actually take it out there and you try to put it in place. Tell us about adjustments. I'm sure you had to make some adjustments as you started to face the real activities that you were going about trying to execute the plan. What was that like?
So once we come up with a plan and we get that molded into its final document, we document everything. Document. Katie has done a great job of keeping. She created a shared drive, and even keeps all of our when our plans change. She archives those. The originals and the newer ones, she archives them all, so we can go back, and at the end of this we can look and we can see what we did, how our PDSAs worked, and really once we finalize our plan, we hand that over to operations, and operations goes out and makes it happen with the help of logistics. And what we do is we again get out there, talk to the staff, talk to the leaders, get that feedback, and if there's something that just needs to be tweaked, that operations usually does that. But if it's something like, hey guys, we need to regroup, then we're going to send this back to planning, and planning's going to look at it. It's a very, very structured process. And again, it goes back to that PDSA. So we have really gotten in a groove with this way of thinking and this systematic way of doing things. And I think that going forward, after this pandemic is finally under control, I don't think we'll ever go back to doing it a different way. This has been so successful in everything we've done that I think that we've just learned this is how we work. This is us now. So
It's just the culture. It's just what you
Yep.
started up as a new cultural technique. That's awesome. Awesome. So I know a lot of the frontline workers put in a lot of long hours, and there was a lot of PPE, and we've talked with the other groups about, and in some of the other hospitals, PPE was short supply at the beginning, and all the supply chain issues, logistics. I've talked to their teams about trying to make sure everything was brought in, but I'm sure that was pretty stressful for a lot of the frontline workers and throughout the process. How did you guys deal with that, or try and reassure or support those heroes and heroines that were there, experiencing it every day? I've talked to groups about, you had the issues with negative pressure rooms, and you had some crash carts, I think, that you were working with, and different things like that were pretty high stress situations.
For us, one of the ways in which we deal with those kind of stressful situations, we actually continue to meet. So each day we had our incident command meeting from 10 to 11, and then we would leave there, do our planning or operationalize whatever we had to do, or go to the gemba. And then later in the afternoon, between 3 and 4, or 4 to 5, something like that, we'd have every day. We'd have a meeting with the managers of every single department. It was a mandatory meeting so that Brian could give them information that they needed to know from the day's events, from the day's plannings, where we stood on PPE, where we, stood on planning for this or that. So I think those meetings, those latter day meetings, helped to get the word out to the managers, who then were able to provide information to their staff. But at the same time, again, being here, being present in the moment, routinely, not just middle management, but also having those senior leaders being present and talking to staff and asking questions, and really just going to where the work is. I think that helped to to calm their fears, and keeping them informed is key. If you don't do that, then the myth train starts and the rumor mill starts. And as soon as we would hear something like we're out of N95 masks, when we really knew that we weren't, we would immediately address that with correct information, and also providing staff with evidence-based instruction, evidence-based practices. I think that really helped.
And in regards to, like Amy was saying, things get started and things get blown out of proportion. So we would, if our staff would say, we're hearing, we don't have any PPE. So we really tried to find out what's the root cause. Like, did something happen? And so they would call and they would request something and they'd be told you can't get it, because we're showing you have this in inventory. So they took that as we're totally out, and that would like spread through like wildfire throughout the building. So when we would hear those concerns, we'd ask, so tell me why you don't think we have PPE, and tell me what you're hearing, so we could go back and correct. And we had to do, education with materials when somebody calls for it. Don't just tell them no, we don't have it, but this PPE has a formal request process, and that that we need to follow. So we tried to stay on top of the rumors like that.
Sounds like the bottom of the blue brain Skip has, which says, show me your thinking. Give me the evidence. And some of the other groups talk to me about, a lot of things were out there on Facebook, a lot of things were out there on social media, and a lot of the larger hospitals were sharing information that was working and some things they had tried. But they said your group was, the three of you specifically, were really good at checking that and making sure it was evidence-based. We didn't just go off of a new idea or something that was a topic of the day. So anything like that, specific things that you either said, yes, this is supported by research and data, or no, that's not, we don't have the data that supports that, we're not going that direction.
One of the examples I can think of is just the FDA's statement that we got with regard to sterilization of the N95 masks, making sure that the ones that we had were the ones that were appropriate for for sterilization. That was a big deal, because we want to be, in compliance with the guidelines, federal guidelines, as well as manufacturer's instructions. So,
and keep them safe, keep the people using them safe from.
Right. You want to make sure that your processes are going to be effective to keep those people safe. That's correct.
And if we ever found anything that we didn't, that maybe we were moving towards, or that someone else made a suggestion to, or even directive from higher than us, if we didn't feel 100% comfortable and didn't have that evidence behind it, it goes back to, again, trust and respect. And I know I keep saying that, but our leadership, our incident command, our senior leaders, trust and respect us enough that we can stop the line, and we trust and respect them enough that we can stop the line, and we can say no, until we figure this out. We have got to stop. We have to make sure we're safe, and we feel very comfortable doing that. And that's something that we're really working on and trying to encourage all the way down to the frontline staff, that, hey, if something doesn't feel right and it doesn't pass the sniff test, stop the line. Just take a time out and let's do it. And so
pull the andon cord, right?
Absolutely,
let's just stop what we're doing.
Absolutely.
So, awesome. So one specific question, and this affected me because I had something planned up, and you guys know my health issues with what I've been that's what I struggled with the last few years. But the vice president went to stopping elective surgery. So it was a period there where there were no electives. I'm sure that really shifted the dynamics at your hospital. Was that really the right decision to do? Did it have a big impact, or was it a minor thing? Or talk to me about that a little bit, and to the audience.
So at the time, not knowing what we were facing, the social distancing, how it was going to spread, looking at places like Wuhan and New York and Michigan and the hot spots we had, really looking at supply and demand, especially of staffing and ventilators and things. I do believe that was the right call. to, make sure that we had beds available if we were to surge and see a high number. I'm your typical quality director, err on the side of caution. And I think that the way it went down and opening up the tents and all the extra work that came because of the state reporting and all of that, those employees, we were able to loop into other jobs and find, opening our tents for our ED and working those, as well as we had to open a COVID command center where we man the results and calling the patients and all of that. So I really think, it was a blessing in disguise, and it was the right thing at the time to do.
And I want to say too, I know it was a financial hardship for a lot of facilities and a lot of people, but in the long run, what that really did, I think, one of the most beneficial things, obviously it probably slowed down the spread, but I think one of the most beneficial things for our facility was the fact that it allowed us to have time to plan and operationalize what we were going to do. And it also gave us, by freeing up those surgeries, it also freed up that staff, like Katie said, to help us man those critical areas of response, like the tents and the ED. And in doing that, we were able to plan, we were able to use other people for other types of jobs. I think it slowed the spread among our employees as well. We were able to really have time to look at the evidence and the rapid fire recommendations that were coming out. It gave us that time to do that. That was critical. And, every hospital typically has a pandemic plan, but typically those pandemic plans are more specific to influenza. We never expected to have a pandemic of coronavirus. While we know there's MERS and SARS-1 out there, we never really anticipated this. And you might have the best laid pandemic plan, and it might be just super beautiful and look like it's really organized, but you can't think of everything. It kind of has to be thought of as you're moving forward. And that's where talking to that staff and meeting with them is so important, because you can sit at a table and plan, or you can get on your feet and plan. And it gave us time to get on our feet and plan, which I think is what made us prevent infections in our employees and really ultimately among our patients.
Sounds like I recall the quote from a heavyweight champion, Mike Tyson: everybody's got a plan till you get punched in the mouth.
That's right.
That's exactly right.
And that's what it felt like.
That's exactly what it felt like.
But allowing those electives, and the extra staff, then, did you do any specific JI training, or would it allow you? Okay, so talk to me about some of those that were key to helping you.
In particular, we created a jib for how we perform the COVID testing with the nasopharyngeal swabs. We also did a lot of our tent work. Was really awesome to see with the training. So we trained with our corporate team on how to use the different products and the different requirements and things for our BOC. And we had set up with the emergency room director, she worked with planning, on how the tents were going to flow and all of that. Well, 2 hours into it, we go to check into it, and the team down there had already, no, we need to do this. They were doing PDSA cycles like on the spot, changing up how they did it, and really created some standard work for other employees as we train, came up with competencies and that nature of training additional employees. But it was really cool to see. I mean, they were, that first couple of days, they were changing things around and how the flow went, and they got it down to a fine science.
And so when you say the tents and the ED, that's the testing process?
Yes, it was in our parking lot.
Okay.
We had 3 tents.
Yeah, I just want to make sure for our audience that may not be in the healthcare industry that they understand that was the testing process and for that. So are there any other people you'd like to recognize, or any other stories that success stories that our audience might want to hear that or find intriguing?
I would like to recognize Matt Farrell. He is our facility service director. We contract with CBRE, but when I tell you he's part of our family, and those guys are part of our family, they are. He is always available at the drop of the hat, and he made magic happen. He worked with planning, he worked with operations, logistics. He was able to convert rooms to negative pressure at the drop of a dime, set up our tents, move our tents when we decided to change locations. He has been phenomenal, and we could not have done this without the support. And he's one of those guys that just, whatever you need, let me do it, I'll figure it out. He never says no. So he's been amazing.
So
and then our COVID call center, if I can recognize somebody, our COVID command center or call center, when we started, our case management director, Beth Lansdale, is the one who took over. It really started aggregating the results and she put a process together on, how we look at those results and how we call patients. And then as the elective surgeries got canceled, someone named Allison Dash, she's fabulous. She came and worked in the call center, and she took over calling the results, training the other employees, created standard work and some processes, some process flow maps for how that work will be done. And then she also took over our plasma donor call center as well when we opened that up, and she created the process flow charts, the processes. She trained the employees for that, as well as there were several other state reports that we had to turn into the state. And so she was really instrumental in creating all the processes for that with very little oversight, just a very high performer. And she also assisted our house supervisor, offloading them because they were very, very, very busy. And she had a positive attitude through it all. And I'm just really proud of both of them.
That's great. Well, all of you, thank you very much for sharing your time, sharing your information, the stories and the planning that you put together, and what it was like going through that. We're starting to see a resurgence in our area where we live now.
This was a little different because not only were we concerned about our loved ones at work, and for DeSoto, that was particularly evident because in this facility, and I've worked at another facility as well, there is such a closeness and family. It just feels, it's just different here. There's a lot of closeness with one another in terms of friendships and just really caring about each other from the top to the bottom. I mean, in sideways, we all are empathetic to one another and what's best for each other. But remember, we're also thinking about our own families. Right. And having that stress, that amount of stress on top of the stress of trying to make sure this place is safe, we could have easily crumbled, but because we were so close to one another and so we worked so well together, we had that support to manage it, to manage the stress. And, laughter certainly helped a lot. Healthcare workers are known for having a unique sense of humor, and I think that was necessary. And so taking that time out to just laugh and love on each other sometimes is critical, especially at work. Anyway, I just think that this was just an extraordinary time where you couldn't just think about yourself anymore. And it really, I feel fortunate to have lived through this. I agree. I really think we're lucky. We think, oh gosh, we're going through a pandemic, but in many ways it changed things for the better.
All right.
And I think it will continue to do that.
Mm-hmm.
Well, again, I want to thank all three of you, and I want to let you know how much everyone appreciates what you do. And I'm sure the communities there in DeSoto County and in the Memphis metro area that go to your hospital and for care are praying for you. We're praying for your families and the support system you guys have at home, as well as your coworkers there. And we're going to continue to do that. And pray that this recent spike that we have can be held under control for you guys, and just pray for your safety and your health. And we're going to continue to do that till we find a vaccine or a therapeutic that helps us through this virus, and so that we beat it. So just want to say we appreciate that, and we're definitely out there in our thoughts and prayers.
Thank you.
Thank you.